Hello. Hello.
Hello, Assalamualaikum. Hello, Assalamualaikum.
Hello. Testing, testing.
Hello,
Hello.
Assalamualaikum.
Waalaikumsalam. Can all of you hear me or not?
Yes, loud and clear.
Loud and clear. Alright. Sorry. Because some technical issues, I cannot get into the online quite early. So shall we start now? Let me share screen. Share. What is this?
Okay, Dr. Rashdan. Let us begin the session with Ummul Kitab first. Al-Fatihah.
Okay. Al-Fatihah. Bismillah.
Okay, Assalamualaikum. Thank you. First, I would like to thank Dr. Rashdan for giving his time to be with us today, updating about management of diabetic ketoacidosis. So this is an excellent discussion, actually, really excellent presentation, because we've had we don't have a pediatric endocrinologist. Dr. Rashdan is the only pediatric endocrinologist covering Kelantan, Terengganu, and Pahang. So we are actually under Dr. Rashdan's jurisdiction. So we'll be discussing lots of cases, Dr. Rashdan. And I think for the past few months, I think we've had several patients coming in with diabetic ketoacidosis, with diabetic, which we are not really adept at really managing it well. So we won't go, I think Dr. Rashdan to discuss however deep he wanted to discuss. And I think without further ado, I'll leave the session to Dr. Rashdan for probably around 1 hour, and then we'll open for half an hour of discussion. Is it all right?
Can.
I'll give to Dr. Rashdan. Tafadhal.
Okay. Bismillahirrahmanirrahim. Thank you, Syed. So, Assalamualaikum. Warmest regards all the way from Kota Bharu. Thank you for the Quantan team for having and inviting me to share some knowledge and experience in the management of diabetic ketoacidosis. Okay, so don't worry about the slide. I will share with Syed later on the slide. So in fact, I have my own the same slide that cater for a so-called lecture by its own lah. So I will share with Syed later. Okay. So today, if possible, we just want to focus on diabetic ketoacidosis. I think this is the very important topic in the sense that majority of you will definitely need to manage DKA at one point of your entire career lah. So hopefully I can highlight some salient point. So hopefully at the same time, we can discuss how it's actually quite different from the adult management. So intermittently, I have to apologize if I have to take a phone call, as well as I have to apologize sometimes that intermittently my line connection is not very good. So suddenly you won't be hearing me, or suddenly I seems to be leaving the discussion, but actually it's because of my so-called internet line is not very stable here in Kota Bharu. Okay, so what we're going to discuss today is DKA in pediatric population and how we best approach it. Okay, so first and foremost, we need to understand diabetes as well as diabetic ketoacidosis. We want to see how we manage DKA in pediatrics and how much it actually differs from adult. I know that all of us is under pediatric department, but some of you maybe come from the adult side or some from ED or have exposure in managing diabetic ketoacidosis in adult. So we want to see how much it differs from the adults. And if we have a time, we can go on and discuss about case discussion. So I want to make it this session as academic as well. So I'm open for any question, and we can always discuss later part of the presentation.
The only
Hello. All right. So basically, this is very important slide. So you know that in diabetes itself, there will be a genetic predisposition factor. There will be an environmental factor, and there will be an immunologic triggers. So these three risk factors: genetic predisposition, environmental, as well as autoimmune or immunologic factors that predispose and trigger a child to become type 1 diabetes. So we are talking about type 1 diabetes. So environmental factors include certain infection, and we know that by the time there will be an immunologic trigger, the beta cell function will start to decline, okay? And by the time it decline to more than 80% decline, so it means that only 20% functioning beta cell, then the patient can have diabetes at this point of time. But although that is at about 80 to 90% decline and only 10 to 20% remaining function, and the patient is already diagnosed with diabetes, so the insulin requirement is not that high until the patient is totally 0% function already lah. So by the time 0%, then you will have a very overt diabetes with higher insulin requirement. But in between that 10 to 20%, that's the so-called honeymoon period. Okay. And by the time the honeymoon period is over and the beta cell is declining to 0%, it will start to have problem. A1C will start to rise, and this is the time that you need to adjust the insulin accordingly. So we have a data in DICARE, age 2006 to 2009, okay, in which we found that 57.5% patient had DKA as their first presentation. Okay, so because we know we have to understand that Malaysia is not, compared to other overseas countries, for example, Finland, in which the prevalence is very high, so they detect the diabetes very much early, even before the DKA. For our population, in view of the prevalence is not that extremely high, so majority of the time, the so-called hyperglycemic symptom, the triad of polyuria, polydipsia, polyphagia, is actually missed by the parents until to the point that the patient developed DKA already. So that's why our prevalence of DKA is relatively higher compared to other countries, because that will be our first presentation. So about 57.5%. So worldwide is quote around 15 to 67%. And this is much more common in a younger age group, less than 4 years old, and those with lower socioeconomic background. And even for a patient that has already been diagnosed as type 1 diabetes, the risk of DKA is about 1 to 10%. Also, there's a lot of reason for that. Omitting insulin, not compliance to medication, or intercurrent illness. So for that established diagnosed type 1 patient, so the risk of DKA is about 1 to 10%. So we have to understand that the pathophysiology of DKA involves two important things. Number one is the relative insulin deficiency, absolute or relative insulin deficiency, And the second one is actually the higher or the elevated counter-regulatory hormone, which is catecholamine, glucagon, cortisol, and growth hormone. So the imbalance between low insulin and high counter-regulatory hormone, it will lead to diabetic ketoacidosis. And this so-called insulin deficiency can happen in those patient first presentation as type 1, patient already on treatment but they didn't compliant or they missed the medication, or those with on insulin pump in which there is a pump failure. So this is very high risk to develop DKA as well. And sometimes it is because of the elevated counter-regulatory hormone, because of the intercurrent illness, for example, sepsis, trauma, and GIT illness, including diarrhea and vomiting. So all of you are very familiar with this slide. So once you have imbalance between insulin deficiency and very high counter-regulatory hormone, it will lead to lipolysis, reduced glucose utilization, increased proteolysis, and also glycogenolysis. And when you have hyperglycemia, subsequently you have osmotic diuresis that leads to pouring out urine and the patient become dehydrated. And on top of that, because of the lack of insulin and high counter-regulatory hormone, you have a lipolysis, a lot of free fatty acid that eventually is a ketogenesis. Ketone itself is very acidic and it causes vomiting, abdominal pain that causing the child to become more dehydrated and eventually diabetic ketoacidosis. So I mentioned the importance of understanding the imbalance between lack of insulin and overproduction or elevated counter-regulatory hormone that leads to the DKA. So majority of the time, we can see that the high counter-regulatory hormone is because of the sickness. It's actually part of the physiology of the body. So by the time, you can see here, by the time the patient is having fever for about 2 to 4 hours, you can see the surge of the counter-regulatory hormone. This is a normal phenomenon. This is a normal physiology of the body. That's why some of the parents, what happened is, when the patient is unwell, they thought that because of unwell, poor appetite, they cut down the insulin because they're afraid of hypoglycemia. They didn't understand that because of the illness alone, because of the infection alone, because of the high counter-regulatory hormones, the blood glucose will be raised, will be elevated. So that's why we say that okay, don't never stop insulin even when you are unwell, because of we know that the counter-regulatory hormone is high during that time. Okay, so again, this is when after about 2 to 4 hours, you can see the raise of all the counter-regulatory hormones. Okay, so coming back to our main focus for today. So what is our goals of therapy in diabetic ketoacidosis? Number one, we want to correct dehydration. We want to correct acidosis, we want to reverse ketosis, and we want to slowly correct hyperosmolality. And we try best to restore the blood glucose to near normal, and we want to monitor the complication of DKA. One of them, the most feared complication will be cerebral edema. I will be touching on that as well. And we want to treat and identify any precipitating factor, including infection. So this is our so-called guideline based on the CPG that has been published in the years of 2015, okay, Management of DKA in Paediatrics. Okay, so I will be repeating myself. We know that DKA is the first presentation of type 1 diabetes in about 57.5% in our population, and the risk factor include young age, delayed diagnosis, low socioeconomic background, as well as country with low prevalence, which includes Malaysia. So first and foremost is by the time you receive a call in ED, in fact, majority of the time the ED will co-manage DKA in their territory, in the ED itself. So assessment of early recognition of seriously ill child and diagnosing DKA. So I think this is very important to note that DKA itself can mimic many disorders. Sometimes we thought that the patient is having acute abdomen, or the patient has bronchopneumonia with severe pneumonia and respiratory distress. But by the time we check the blood glucose, we finally understand that, oh, actually, the patient is having diabetic ketoacidosis. That's why I always emphasize to our ED colleagues that in all ill child, please check blood glucose. So at the by the time we check the blood glucose, then we know that, oh, this must be when the blood glucose is elevated, then we want to make sure whether this is just a stress response or this is indeed a diabetic ketoacidosis. So principles in management in ED include acute resuscitation, immediate management in ED, continuous evaluation, and subsequently total DKA care. So in terms of clinical features, the patient may present with nausea, vomiting, abdominal pain, which is the typical history of ketosis. The patient may present with evidence of dehydration, for example, lethargy, poor pulse volume and everything. The child may have altered conscious level, tachycardia, small breathing, and this and when you get back to the parents, there will be a classical hyperglycemic symptom, for example, polyuria, polydipsia, weight loss, and polyphagia. And then, of course, in DKA, we want to diagnose DKA based on this criteria. Okay, for number one, you need to have a high blood glucose of more than 11, pH of less than 7.3, bicarb of less than 15, and presence of ketonemia or ketonuria. So ketonemia is more than 3 millimole per liter, and ketonuria of more than 2 plus. So some of the center, we cannot check the blood ketone, so we have to use urine ketone strip to diagnose DKA. But you have to understand that urine ketone is not very sensitive as compared to blood ketone. Okay, and then to make things very easy, so we will classify and categorize DKA into mild, moderate, severe, depending on the biochemical parameters, rather than depending on the clinical parameters. Because we thought that when we set up and the guideline, it's very difficult to standardize clinical parameters as compared if we can standardize the biochemical parameters. Hence, the panel decided that, okay, we will categorize DKA depending on the biochemical parameters. So we divided into
Hello, Rashdan. Rashdan.
sorry, I suddenly off the line, is it?
Yes, you need to restart Rashdan.
Sorry?
You need to reshare again the slide.
Okay. So we are here just now. Am I correct?
You can't see your slide. Then I'm going to stop sharing and then start resharing again.
Oh, okay. Sorry. So sharing. Okay, yes. Okay, screen share. Okay, are we online? Yes.
Rashdan, I just want to ask you, urine ketone, the problem with urine ketone, is it false negative or is it false positive? Is it like you may not detect or is it not specific enough?
Okay, so Syed, the problem with urine ketone is it will be lack of it's not very sensitive and it will be lack of response. So in the sense that when your blood ketone is positive, your urine ketone can still be negative. And during resolution of DKA, when your blood ketone is already negative and yet your urine ketone is still positive, so it will be delayed in terms of the sensitivity and response to the actual clinical DKA at that particular point of time. So for example, when you have a hyperglycemia, when you have an acidosis, and yet your urine ketone can be still negative, but if you check blood ketone, it's positive already. That's the difficult part about the urine ketone.
Thank you.
Okay. All right. Sorry. So I was here just now. So you know that we categorize it into mild, moderate, severe depending on the pH as well as bicarbonate. 7.3, 7.2, 7.1, very easy to remember. 15, 10, 5. That's why we are more into biochemical parameters in diagnosing and categorizing the DKA rather than clinical diagnosis. So why this so? Because they found that it is very subjective in terms of clinical parameters, and different physician or different doctors has different identification of the hydration status of the child. So that's why maybe if you asking me, I thought that the patient is 10% dehydration. So you ask another doctor, or the doctor feels that it's maybe around 5% dehydration. So a lot of discrepancy between the clinical parameters. That's why the panel decided that, okay, just use the biochemical parameters to diagnose and to categorize the DKA. So, but having said that, in terms of clinical assessment, the three most useful signs for predicting more than 5% dehydration include prolonged capillary refill time, abnormal skin turgor, and also abnormal respiratory patient. And although shock is very rare in DKA, the presence of shock itself will suggest more than 10% dehydration. So in terms of management, first we have acute resuscitation care, and subsequently we have to proceed with immediate management that includes our fluid therapy, potassium therapy, insulin therapy. We will touch on bicarbonate, and subsequently we need to have a continuous evaluation. So I think majority, if not all of you, are trained in acute in APLS, Advanced Pediatric Life Support. So in terms of emergency assessment and management, it will comply to the standard pediatric resuscitation guideline lah. So for Malaysia, now we are into APLS. So, but to highlight a few things, we have to secure the airway and give oxygen. We have to insert NG tube to prevent aspiration in an unconscious patient. We have to assess the severity and dehydration. We need to get an venous access. We have to send blood glucose, blood or urine ketone, electrolyte, and blood gas as well. And then we want to monitor the cardiac monitoring and ECG for evidence of hypo and hyperglycemia. And we will categorize the bladder, especially in unconscious and very ill young patient. We consider to start antibiotic for those having fever. And what more importantly is we need to weigh the patient. So we need to check what is the weight of the patient at that particular time. All right. So I think the most important part in the management of DKA will be our fluid therapy. And majority of the time, by giving appropriate fluid therapy alone, the blood glucose will come down and the acidosis itself will start to show evidence of response lah. Okay. So we always emphasize that the fluid replacement should begin before the insulin therapy, usually about 1 to 2 hours even before the insulin therapy. So majority of the time we say that to the ED people, okay, don't start the insulin, but you can run your fluid first lah. So we need to know how much we should given to a child. So we can divide it into 3 main category lah, depending on the clinical status of the child. Number 1 is DKA with decompensated shock. Number 2 is actually DKA with compensated shock lah. Severe volume depletion but not decompensated shock. I think patient is in compensated shock. And lastly is DKA with mild to moderate volume depletion, which is around 5 to 7.5% dehydration. So if patient is in decompensated shock, it means that patient is shocked, poor pulse volume, tachycardic, CRT is delayed, and the blood pressure is hypotensive already, decompensated shock. We need to run 10 to 20 ml per kilo of normal saline as quick as possible and reassess. So this is compared to our standard pediatric resuscitation lah. But we will be more careful if patient in compensated shock, but the BP still maintainable. So those patients in second category whereby they have a severe volume depletion, they have tachycardia, they have poor pulse volume, they have delayed CRT, but the BP still maintainable, still normal, still not hypotensive. So we still need to run fluid bolus at around at 10 to 20 ml per kilo, but longer duration, 1 to 2 hours. Usually what I usually do is 10 ml per kilo over 1 hour, and we reassess. If the patient still in compensated shock, we will run another 10 ml per kilo over 1 hour and reassess up to maximum 30 ml per kilo. Although we put here in the guideline 30 ml per kilo, it depends on the clinical judgment of the particular physician lah. If you feel after 30 ml per kilo and yet patient still under volume, intravascularly volume depleted, so you need to run some more fluid resuscitation lah, because this is a life-threatening condition. But as a per guideline, we say that okay, every 10 ml per kilo, we reassess back. Okay, and majority of the time, you don't need to exceed 30 ml per kilo. So if the patient came into you with just mild to moderate volume depletion, about 5 to 7.5% dehydration, majority of the time you don't need to run bolus because the patient still evidence of dehydration, but completely not in shock. So you don't have to run fluid bolus. Okay. So subsequently, after your fluid boluses, your first line of acute resuscitation, your fluid boluses, then the subsequent fluid therapy depending on the clinical scenario again. So for the first 2 clinical scenario in which the patient is in decompensated shock as well as compensated shock, following the bolus you have given, the subsequent rehydration and also maintenance therapy must be induced over 48 hours. And the resuscitation bolus should not be included as part of the total fluid requirement. Remember that many years ago, we always minus the bolus when we calculate for the correction fluid and also maintenance fluids. Nowadays, we said, okay, whatever you give as a bolus, that's as a bolus to restore the perfusion. But the subsequent fluid therapy, you have to calculate the correction, the dehydration, 7 to 10% correction, plus your maintenance over 48 hours, and you shouldn't minus the bolus that you have given before, okay? And majority of the time, the fluid that you calculated, the rehydration plus maintenance, should not exceed 1.5 or 2 times the daily maintenance requirement, and we use normal saline as our fluid of choice for the first 4 to 6 hours before switching to other solution. Okay, and the decision to switch depending on the patient hydration status, patient serum sodium and osmolality, and also sometimes if the patient is stable, we can start patient orally. So I think to recapitulate this slide, first you give bolus, 10 ml per kilo, 10 ml per kilo, 10 ml per kilo, usually not exceeding 30 ml per kilo depending on your clinical judgment. And the subsequent fluid So you correct. Okay, for example, you want to correct for 10% correction. So 10% over, you calculate the 10% correction over 48 hours plus your usual maintenance for that 24 hours. And both of these correction and maintenance, you remember split the drip. So one is for the correction, one is for maintenance. Nowadays we say that for the first 4 to 6 hours, just use this one single fluid regime, which is your normal saline, but the volume is actually cater for both correction, rehydration, as well as maintenance. All right. And then after 4 to 6 hours, then you decide, okay, how we should go about it in terms of the fluid therapy, depending on the patient clinical status, sodium, osmolality, and input-output chart, everything. So, but for the first 4 to 6 hours, just use the normal saline, and the volume is actually hydration plus maintenance. Okay. So for those mild to moderate volume depletion, usually you just need a rehydration and maintenance, same principle over 48 hours. And those with mild dehydration, most of the time you maybe just allow orally, and intermittently you need IV fluid to maintain the total daily fluid requirement. But this is for those very mild to moderate dehydration in which you don't need to give bolus to start with. All right. Okay. So any question for the fluid before we go to the management of the potassium? Any question?
Any issue? I think no, we can proceed, I think.
Okay, thank you, Syed. I just wondering whether you can hear me well, because Syed sounds very far away and breaking off lah. But the rest of you can hear me well. I hope so.
Can. Clear.
Can I? Okay, thank you very much. Okay, so now we go for the potassium. So so we can divide it into normokalemia, hypokalemia, and hyperkalemia. So you need to understand that in DKA itself, the total body potassium is depleted. So indirectly, we need to give some potassium supplementation because our total body potassium in DKA is depleted. So how much is depending on the serum potassium level. So if you have a normal potassium, so you can start the potassium inside the drip, okay? And the subsequent potassium replacement should be based on the serum potassium measurement serially. So how much to start? You can give 1.5 gram KCl in per pint. So we can just, okay, 1.5 gram KCl in per pint. So for those who presented with hypokalemia, the potassium replacement can be started even during the fluid bolus that you are giving when the patient is in shock. That's how we understand this slide, okay? And for those hyperkalemia, you only add potassium on your drip once you have a good urine output documented. And please bear in mind that the potassium replacement should not exceed 0.5 millimole per kilo per hour. Okay, so I give you a scenario. So now you are dealing with a patient diagnosed with DKA, and you found that the patient is in compensated shock. So you decided to give 10 ml per kilo per hour, 10 ml per kilo of normal saline. So if you find that the potassium is low during that resuscitation, earlier part of resuscitation, you can add about 1 gram KCl in that particular pint, so that when you give the fluid bolus, is actually contain both normal saline, on top of that the KCl. Okay. So for the normokalemia is, for example, you are giving for the same principle, patient is actually in compensated shock, so you are giving bolus normal saline, but the potassium is normal, so you don't have to add potassium in your normal saline bolus. So after 10 or 20 ml per kilo, you restore the perfusion, and then now you on the subsequent fluid therapy. So I mentioned to you that for the first 4 to 6 hours, just use normal saline. How much? rehydration plus the maintenance. So you can add 1.5 gram potassium per pint on that particular normal saline drip regime that you are start. So something like that. Okay. Okay, now we're going into the part of insulin. Okay, so insulin therapy should begin at the rate of 0.05 to 0.1 unit per kilo per hour after 1 to 2 hours of fluid replacement therapy. So we are now emphasizing that no bolus of insulin. Previously, many years ago, people just simply give 10 units of atropine. So we said, okay, no more that practice. Even adult not practicing that, you know, bolus that injection atropine insulin. So now we are into infusion insulin, and we will keep this 0.05 to 0.1 unit per kilo until resolution of DKA as evident by pH more than 7.3, bicarb more than 15, and blood ketone less than 1. Okay, for some patients, especially young children less than 4 years old, especially young children less than 2 years old, rather than starting at 0.1, we might consider starting at 0.05 because they have this marked sensitivity towards insulin. So the standard practice, we say that, okay, always start at 0.1, but in certain group, especially young children less than 4 years old, sometimes I'm not starting at 0.1. I will just start the patient on 0.05 unit per kilo per hour, and we monitor subsequently. So either we need to increase the insulin or decrease the insulin infusion. Okay, so for the bicarbonate therapy, we said that no bicarbonate because bicarbonate therapy may lead to paradoxical central nervous system acidosis. It can cause hypokalemia and very high risk of cerebral edema. So for this guideline, we always away from the using of bicarbonate, but certain guidelines actually emphasize that you can use bicarb in the life-threatening hyperkalemia, or even if the very low pH less than 6.9 that affect cardiac contractility lah, echo confirm. But if best possible, try not to give bicarbonate lah. Majority of the time, you can get away with just a proper fluid and as well as insulin therapy. Okay. And subsequently, for the continuous evaluation, we want to monitor hourly vital sign, hourly GCS, hourly blood glucose. We want to taper down the insulin. We want to have a good IO. And then 2 to 4 hourly, we need to check the RBS. We need to check the blood gas and serum electrolyte. We want to monitor the calcium, magnesium, phosphate, and want to monitor the ketone as well. Okay. I think before we proceed, I just stop here for any, and I will take any question regarding the earlier management of the DKA. Any question?
So Dr. Rashdan, the drip, we always start with D10, right? D10, like half saline or quarter or normal saline D10. For example, like nowadays, I mean, for example, the PITS protocol suggested to use normal saline rather than half saline. So we have to use normal saline D10 as the initial drip. Am I right?
Okay, betul. Okay, Alwi, macam ni. So I think to make very easier for you, so now you have a patient. So you decided that, okay, what is the clinical status of the patient? If the patient is shock, either compensated or decompensated, you want to give fluid bolus. That one is the usual normal saline. Okay. So once you restore the perfusion, and then you don't have to give bolus, so now you decide your subsequent fluid therapy. So when you deciding your subsequent fluid therapy, the easiest way is just get a normal saline. Just get a normal saline. So for that normal saline, fine. You add 1.5 gram KCl if the patient is normokalemia lah. Okay, put 1.5 gram KCl. The rate you have to plus lah. How much is the correction? 10% over 48 hours plus the maintenance over 24 hours. For example, let's say your correction is your calculated correction over 48 hours is 15 mils per hour, and your maintenance is another 15 mils per hour for that 24 hours, then the total volume will be 30 mils per hour. So you said, okay, run 30 mils per hour of normal saline, in which that normal saline have 1.5 gram KCl per pint. So you use that saline for the next 4 to 6 hours. All right. So after 1 to 2 hours, you start your insulin therapy at 0.05 to 0.1 unit per kilo per hour. Okay, now majority of the time what happens is your blood glucose will fall down, but your DKA is not yet resolved. The pH still acidosis, the ketone is still there. So you know that, okay, I cannot cut down the insulin infusion. I have to maintain that 0.05 to 0.1 unit per kilo per hour because the DKA hasn't resolved. And yet the blood glucose is now falling down. So now you have to add the dextrose inside the drip. So what dextrose you need to add? It depends lah. So you can add D5 dulu, or kalau you biasanya kita add D5 dulu lah. So now you are using normal saline D5 plus 1.5 gram KCl per pint, run at 30 mils per hour because your blood glucose dah fall. So how much falling tu? Biasanya kita kata if fall more than down to 17, let's say your blood glucose is to start with 30, and now actually fall too drastically lah, dah bawah daripada 17, bawah daripada 14, you have to add the dextrose inside the drip. Okay? Ataupun fall rapidly lah, more than 5 millimole per liter per hour. So for example, kalau the initial blood glucose is 30, you expect that it should fall around 25, tapi you remember daripada 30, dia fall into 20. Still above 17, but the rate of falling is too very significant, right? Daripada 30 turun 20, then itu pun you kena add dextrose. So tak semestinya you kena add D10, you can add D5 first. Tapi kalau you dah add D5, then you follow up lah subsequent blood glucose. You kata, alamak, still DKA not resolved, and yet the blood glucose still falling. Then you add D10 ataupun D12.5 depending on the clinical judgment, clinical scenario at that particular time. Faham tak, Alwi?
Faham. Okay, good.
Okay, alright. Cool. Any other question?
Rashdan.
Yes, Syed.
I'm just trying to make life a bit complicated. Any
You
rule?
are a complicated person, Syed.
Any rule for venous lactate as bolus? So instead of giving normal saline bolus, we give venous lactate because it has potassium in it as well.
Okay, to be honest with you, sebenarnya boleh saja. You can give venous lactate, you boleh bagi Hartmann, because as far as the resuscitation fluid is concerned, it will follow the standard pediatric life support punya resuscitation. I think I will emphasize. I think the take-home message is about the volume. So you can use venous lactate, you can use Hartmann, tapi the volume must be the same. So kalau you have a decompensated shock, it will be 10 to 20 ml per kilo stat ASAP, as quick as possible. Tapi kalau you are in compensated shock, so you have to give 10 ml per kilo over 1 hour, reassess 10 ml per kilo over 1 hour. So but the choice is actually depend. You can give venous lactate, but as far as making a so-called CPG, they standardize using normal saline. Tapi sebenarnya kita nak guna venous pun boleh, nak guna Hartmann pun boleh. Kan? Betul tak? Alright, cool. Any other question?
Hello, Assalamualaikum, Doktor.
Waalaikumsalam. Hami Riza, is it?
Yes, Doctor.
Alright.
Doctor, I would like to ask about the formation of DKA.
Okay.
Regarding the formation of DKA, I did read about the symptom or clinical features of diabetes mellitus, and it is divided into early and late symptom. Early symptom is mainly the classical symptoms such as polydipsia, polyphagia, and weight loss, and polyuria. Meanwhile, for the late symptom is like hyperventilation, fluid odor on breath. So for the late symptom is actually nothing but symptom of DKA, right?
Betul.
But
So actually,
I want to know how fast or how late for patient with underlying diabetes or uncontrolled diabetes mellitus can develop DKA, doctor? Is it
Sorry, I didn't
early?
get you.
I would like to know how fast or how late patient with underlying uncontrolled diabetes mellitus can develop DKA.
Okay, good question, Hami. Okay, so first, symptoms of hyperglycemia. So remember the 5T: thirsty, thin, weight loss lah, thinner, toilet means polyuria, and then tired, easily tired, and test. When they do the test, they noted that blood glucose is high. So at least remember this 5T lah. All right. So for the symptoms of DKA, that's typical symptom: nausea, vomiting, abdominal pain, small breathing. That's why sometimes it can mimic other condition, for example, acute abdomen and pneumonia. Okay. The next question is how fast a diagnosed or established type 1 patient can develop a DKA. Very fast. Okay. It depends on the insulin regime. If the patient is on basal bolus insulin and the patient is injecting the basal and non-compliance or omitting the bolus insulin, the DKA will develop much later because the basal still cover for whatever lack of insulin inside the body. But if the patient on basal bolus insulin and yet they miss the basal insulin, then it's much more cepat. Okay, earlier they develop DKA. And for those on insulin pump, by the time the insulin pump failure, less than 1 to 2 hours, they can develop DKA because insulin pump is actually continuous insulin infusion to the system. And by the time you have the system king or failure, so by 2 to 4 hours maximum, they will develop DKA already. Okay, so it can depend on the clinical condition of the patient. Okay, good. Any other question?
In patient with DKA kan, Dr. Rashdan?
Betul,
how about the threshold for intubation? Because we know the respiratory distress is very difficult to assess because the respiratory distress is contributed.
So what do you think, Alwi? Do you want to intubate my DKA patient in your ED?
Usually I will try to hydrate them first. And then if the airway is still patterned, so as long as the GCS and also the airway is patterned, then the respiratory distress becomes second. Not like pneumonia, sometimes severe respiratory distress we intubate to prevent respiratory failure kan. Tapi kalau usually in DKA, kalau myself, I will assess more on the GCS and also mainly the GCS lah rather than the respiratory distress. Betul, Rashdan? Alah. We lost him.
Sorry. You know, technical errors again. We are here in Kota Bharu. The line is not so great. Not like Kuantan. Okay. So, Alwi, are you there?
Yes.
Okay. So, what do you think? Do you want to intubate a DKA patient in your ED?
Again, I'll base on the as long as they can they can maintain their airway and also the GCS not dropping further lah, more than 8, then I won't. I've got higher threshold to intubate rather than looking at the respiratory distress.
I think that's a sensible answer. So what I'm trying to say is, we will say that try best not to intubate the patient. Try best not to intubate the patient lah. Why? Because we always feel that you cannot take over the ventilation of hyperventilation of DKA. You know, when you intubate, you cannot take over the hyperventilating that the patient is now physiologically try to get rid the acidosis. So if try best, if possible, not to intubate the patient lah. But if I make a rules that do not intubate, then very dangerous as well, because sometimes, yes, you need to intubate the patient, especially when the patient have developed a complication, for example, cerebral edema. So I think here you need to use your clinical judgment lah. If you feel that the airway is still maintainable, then I will try not to intubate. Okay, but if you feel that the airway is no longer maintainable, that you might handling a case of complicated with cerebral edema, then by all means, please actually intubate the patient. Okay, any other question? Okay. Okay, so now we will like to have a look comparatively, depending on our CPG with other guideline worldwide. So we have ISPEC 2014. Let's bear in mind now we have to ISPEC 2018 already, 2018 or 2019. We have this so-called British guideline 2015, and we have the American guideline in 2006. So in terms of fluid resuscitation, ISPEC also mentioned 10 to 20 ml per kilo over 1 to 2 hours. The British Society said that for mild moderate DKA, no bolus, same with us. In short, give 10 ml per kilo times 1 only. Okay. And then for the American guideline, they also mentioned about 10 to 20 ml per kilo, about 1 to 2 hours infusion. So majority of the time is similar to our guideline. And then in terms of the subsequent fluid, so either deficits plus maintenance. So for the ISPEC guideline, 5 to 10% over 48 hours, same. And then they for the British, they said that if you are giving bolus more than 20 ml per kilo, you have to minus the bolus. Our guideline said no need to minus. And then the AD also mentioned that the fluid correction must be over 48 hours. The maintenance therapy will be the same. The type of fluid that you choose, you choose same normal saline, but subsequently you can for the ISPEC, you said they said that you can cut down to more hypotonic saline, but for the British and ADA maintain normal saline. I think the principle is almost the same lah. You just use the normal saline for the first 4 to 6 hours, and the subsequent choice is depending on your clinical status, your biochemical parameters, for example, your sodium, your acidosis, and everything lah. All right. So they mentioned that if the patient develop cerebral edema, you have to cut down the fluid by 1/3, and then crystalloid rather than colloid. Okay. For me, it always depending on the clinical scenarios. Okay. And then the use of bicarbonate, they say, okay, no, unless life-threatening hypothermia or unless there is a very acidosis environment that may affect cardiac contractility. So just to recapitulate, so basically our CPG is actually commendable lah, same, more or less same with the CPG as well lah, the ISPEC guideline, the British guideline, as well as the American guideline. So I think we can have another session of diabetes. Maybe not next week lah. Syed next week raya lah. Syed, semua orang nak raya hari Jumaat. So we can reschedule some other Khamis but not next Khamis lah. Orang nak raya, nak sembelih lembu lah. Okay, alright. So we're going to discuss about that later lah. So now we talk. I will talk about in cerebral edema. So for the cerebral edema, basically, you need to have high index of suspicion that the patient might already develop cerebral edema. The mortality rate from the DKA is very small. patient died because of DKA is only about 0.15 to 0.3% only. But majority of the time, this mortality is secondary to cerebral edema. So you just imagine that the mortality is generally very low, 0.15 to 0.3, but 60 to 90% of this mortality is secondary to cerebral edema. That's why we need to tackle cerebral edema. And then among those survive the cerebral edema, 10 to 25% will have significant morbidity. So we need to understand there will be a diagnostic criteria, major and minor criteria, and how to manage cerebral edema. So how DKA leads to cerebral edema? Number one, the disease, the DKA itself. Because of the acidosis, the patient has reduced cerebral blood flow. Because of the dehydration, the patient has reduced cerebral blood flow. And once you have reduced cerebral blood flow, there will be a cerebral injury and cytotoxic edema. So the DKA alone, not related to treatment, can have cerebral edema because of the cytotoxic edema. But of course, when you have inappropriately managed the patient, the DKA patient, because of overzealous fluid or rapid fluid, you can have cerebral edema, and also you can have the repercussion injury that leads to vasogenic edema. All right. So that's why we always say that, okay, in compensated shock, don't run the fluid too fast. Run over 1 to 2 hours, something like that. And the amount is around 10 mils per kilo, rather jump to give 20 mils per kilo. Okay, so you have a long list of how to diagnose cerebral edema. You have diagnostic criteria, you have major criteria, and you have minor criteria. All right. So the management, the same principle, pop up the patient 30 degree, reduce the, so whatever fluid you are giving, you know, the rehydration fluid, the maintenance fluid, so you just cut it down to 1/3 of whatever fluid you are giving now. You may consider IV mannitol, you may consider hypertonic saline, you may consider intubating the patient if there is impending respiratory failure or you're not intubating the child as yet, and you need to do the cranial imaging once it's feasible to do it lah. But of course, we want to manage the patient first lah. If you feel that you can send to CT scan, better send to CT scan. But if the patient is not stable, please stabilize the patient first. So I will, okay, any question on cerebral edema? Any question on cerebral edema?
I think maybe because I think because usually we use half saline kan. Previously we use half saline to treat. Hello. Okay. Usually kan we use half saline to treat dehydration in pediatric kan. I think that's why I think it's quite important to use normal saline in type 1 DM. Because rapid reduction in DKA, because rapid reduction in the saline in the sodium level will actually triggers will lead to cerebral edema.
Okay, if you are asking me and Syed, you can see the shift. Okay, so during our time many years ago, I'm still young. Syed is older than me. I'm still young. But many years ago, we use quarter saline. Then we said that okay, quarter saline is very hypotonic. So then we go for half saline, and now people emphasize on normal saline. And I think majority of our knowledge about this so-called tonicity is actually based on the fact of management of dengue fever. That's why in the dengue fever we say that because of the plasma leakage and everything, so they want to have a more isotonic. That's why we use normal saline. So I totally agree with Alvi that nowadays we are actually towards the using normal saline because of the tonicity. Because we know that when the child is very unwell, very ill, there's some degree of plasma leakage as well, and then we don't want a rapid fluid shift between the tonicity, hypertonic, and everything, because we are afraid of this so-called cerebral edema as well as pontine demyelination lah. But having said that, I think more importantly is actually you need to monitor the child. You need to serially evaluate and monitor the child. Sometimes when you give too much of normal saline, what will happen? When you give too much of normal saline, the chloride contents of the normal saline will lead to hyperchloremic metabolic acidosis. So what happens if we are into normal saline and keep on using normal saline, I'm afraid that the chloride content can go up, and then majority of the time, most of you will just see the sodium level, but you will forget about the chloride level. So sometimes, and then you say that, hey, why the patient has persistent acidosis, and you thought that the DKA is not resolved, but the blood glucose is actually came down very significantly. And then you can see the ketone also actually started to come down, but your acidosis is persistent. So the persistence of acidosis may be not because of the DKA, but because of the hyperchloremic metabolic acidosis. So Ali, yes, I emphasize on normal saline, but please be careful. What more important is actually monitor. So if you feel that the child has have developed hyperchloremic metabolic acidosis, then please actually you can use side drip lah, normal saline and half saline. Doesn't mean that you have to change to all the half saline, but you can use a 2 drip bridging lah, the side drip. You know, maybe the correction using normal saline, but the maintenance using half saline and everything. And also how much potassium inside the drip depending on the serial potassium level. That's why the guideline always emphasizes the first 4 to 6 hours, but the subsequent after that 6 hours, depending on the clinical status and biochemical status of the child. But a good discussion, yes, we want to use normal saline, but at the same time, please be careful on hyperchloremic metabolic acidosis. Very good. So, any other question or input or opinion? Sorry, I keep on drinking because I'm very passionate person, so I cakap tu very passionate, so I cepat dahaga because I'm very passionate person.
Actually, I found an article. I think about a few months ago, maybe last year, end of last year.
Okay.
I found a study that they use glargine. They use the long acting rather than using infusion. They use long acting analog insulin. The management of DKA. What do you think about it? Is there any like lot of
we are still not practicing that. We are still using short acting. As per infusion lah. So we haven't practiced using the longer acting one, because the problem with the because now the patient is in the state of insulin deficiency, and we want to and also the counter-regulative hormone. So we want to actually try to restore the osmolality, try to switch off the ketosis, and try to restore the blood glucose to a near normal as soon as possible lah. But at the same time, not in the aspect of developing cerebral edema. That's why I think for the time being, even in the ISPEC 2018 and 2014, they still emphasizing on using short acting as an infusion to manage decay. But a lot of study is going on, and some of the studies say that using 0.05 unit per kilo per hour is as good as 0.1 unit per kilo per hour. That's why I will emphasize that smaller children, it's not wrong to start with 0.05. But more importantly is to monitor the patient and to see what happened after you starting this particular regime. Okay. So yes, there's a few studies going on, but for the time being, we are still sticking on the using of short acting as our infusion. Okay, any other question? Okay, maybe quickly we just go through how much we manage DKA pediatric compared to adult. So basically in adult, they have higher mortality rate. So the overall mortality rate is around 1 to 5%, And then majority of time, the precipitating factor is infection or missed therapy or some acute coronary syndrome and cardiovascular accident lah. So they use the same diagnostic criteria for DKA, but rather than using the standard biochemical parameters, their definition of severe DKA as per follow lah. Venous bicarb less than 5, blood keto more than 6, pH more than less than 7.1, hypokalemia, GCS poor, oxygen saturation, systolic blood pressure, pulse and everything. So we just use the venous bicarb as well as venous pH, but we don't use any other criteria to diagnose severe DKA. All right. And in terms of management, they go hours by hours. So as you can see here, they start insulin very early. So they say that, okay, no more bolus insulin, but they start insulin very early during the first hour of managing the DKA. So we said that, okay, please give fluid first. After 1 to 2 hours, you start the insulin. But adult, they start insulin right in the beginning during the first hour management. And then in terms of the fluid and potassium, they having is this fixed huge volume of bolus lah. So they just give 500 mils, then 500 to 1000. Then we go into like 10 mils per kilo, 20 mils per kilo, but they just fix the volume lah, 500 mils, 500 to 1000 mil. And they even use gelafandin and then as their choice of fluid. So they can go up to 1000 and 1000 mil during the first 60 minutes of their management. Okay. And then they mention what role of bicarbonate. So they say that the use of intravenous bicarbonate is not indicated to correct acidosis, but they always mention that this but consider it in the life-threatening hyperkalemia or in the poor contractility as well. Okay, so the subsequent is actually fixed volume, hours to hours. You can see, okay, second to 6 hours. So they say, okay, run this much, 1000 mil, run 1000 mil. So their fluid is very fixed volume. As compared to us, we say that, okay, the subsequent management, use normal saline, calculate the hydration, calculate the maintenance, and then give, after 4 to 6 hours, we assess, something like that. Okay. So they're depending on hours of therapy lah. And they try to resolve the DKA within 24 hours. So we don't put a target. Okay, but they trying to target to DKA resolution within 24 hours. And in adult, please be careful on euglycemic DKA, especially those on SGL2 inhibitors. So the blood glucose can be normal, and yet the patient is having diabetic ketoacidosis. I think for adult, not much of a problem. I think just to highlight a few salient points, because some of you may be trained by the ED or trained by the adult physician. So do we have time for a quick case study, or you want to ask question now? I'm very open.
We have time.
Sorry, Syed?
We do have time. We have time. Rashdan, before you give case study, can I ask? When would you change? Okay, so when you have a patient with DKA, first you give fluid. After 2 hours, then you start, and then you start insulin infusion. So I have two questions. The first one is, I saw many centers, many hospitals, they use different sliding scales. Do we have any like a standard sliding scale to be used?
Okay.
Sliding scale.
Okay.
That's one question. The second one is, when would you change from the sliding scale insulin into a bolus type of insulin?
All right. Okay, Syed, to be very honest with you, I personally don't have sliding scale. For me, my sliding scale is not in terms of management of DKA. For me, the sliding scale is in terms of management for operation. So let's say you have a type 1 patient going for a surgery, then I will put the patient on a sliding scale because we want to tackle the insulin, because we want to make easier for the NS, for the surgeon, and for our nurses to tackle to cater the insulin depending on the blood glucose. But for a DKA per se, DKA itself, I don't have any specific sliding scale. Yes, I understand that some of the center use sliding scale, but for me, the use of sliding scale can be quite dangerous in the sense that because it's a very fixed kind of thing. You know, if the blood glucose less than this, you do this, if that. Okay, and we know that in DKA, more importantly is we want to monitor the patient, we want to see the resolution of the DKA, hence we want to see the pH, we want to see the ketones, we want to see the blood glucose. Sometimes the patient is still in DKA and yet the blood glucose fall very fast, that's why we need to add on it lah. So, but if we are putting the patient on sliding scale, we keep on cutting down the insulin because the sliding scale is based on the blood glucose and insulin. So, but we don't want that because we know that if the patient is still in DKA and yet the blood glucose is fall down, rather than cutting down the insulin, we need to add on the dextrose inside the drip. So I don't have a particular sliding scale. So, but I give you a clinical scenario in which may be relevant to your question. So, for example, you have now managing a DKA. So now 10 or 12 hours into management, and now it's around 10 p.m. at night, and you see that the DKA start to, resolve lah, resolution of DKA, but around 10 p.m. at night, 1 a.m. in the morning. So you know that you want to convert the basal bolus not in the middle of the night, because you want to transition and converting to the basal bolus only that following morning. So tonight, you have a condition whereby DKA is actually resolved, but you need to play around with the insulin. So hence, that's the time where the sliding scale may came into the picture. Faham tak? Macam kalau biasanya kalau kita dah manage DKA, kita dah rasa patient is into recovery and resolution, kita nak transition into the basal bolus. But this thing happen in the middle of the night, and you don't want to transition into basal bolus in the middle of the night. So that's why just to buy time while waiting for the morning untuk you transition to basal bolus, then that night you can put on a sliding scale. So because I don't want to put a sliding scale much earlier during the earlier part of management, in which masa tu DKA belum resolve. Kalau DKA belum resolve and you put the patient on sliding scale, so one of the parameters is cut down insulin, omit insulin, then that dangerous lah, sebab tu it will be yo-yo lah. Gula turun naik, but the acidosis pun tak pernah resolve. Okay, so your second question is transitional. I think transitional, we try to discuss the next topic, but for me, I will transition the child at the nearest meal hour. Contohnya kalau you punya DKA to resolve in the morning, I will transition to basal bolus during the lunch. Kalau dia resolve masa after lunch, we try to do it after dinner. But the problem is kalau dia resolve after dinner, then you tak ada orang berani kan masa tu on call nak transition tengah-tengah malam. Kecuali Dr. Syed rajin lah duduk kat situ bersama patient. Dr. Rashdan tak rajin lah. Jadi what we do, sometimes that overnight we put the patient on sliding scale, and the first thing in the morning we transition the child lah. So transitioning there is no hard and fast rule. It's about an art as well. So what I usually do is, we know that there is a two component, basal and bolus. We know that we need to understand how much insulin requirement per day. So our total daily dose or total insulin requirement per day can be either we just simply take 1 unit per kilo per day, 1 unit per kilo. Let's say for example 20 kilo child, we say okay, the patient need 20 unit of insulin. Or the other method is we can calculate whatever the child needs the first 24 hours earlier during the infusion. So, but I will go for the later, I will go for the first style lah, in which biasanya I malas nak kira how much the insulin requirement for that particular 24 hours before we transition. You can do that actually. That is maybe the better way. But I always start with 1 unit per kilo per day. So you know 50-50 lah. Basal 50, bolus 50. So let's say for example you have a 20 kilo child, you know that the child needs 20 unit per day. So you can start 10 unit of basal insulin, either glargine, levemir, or insulatard. And then if I start in the morning, I will give the half dose first lah. So I will give 5 units stack during the transition, and the night after that, I mean the following and the following dose will be at night, which is because we are giving glargine always at night. So we just give another, you know, that fixed 10 unit overnight. So macam mana nak bagi contoh? Okay, for example, you are now transitioning, tapi bukan malam lah, you transitioning during breakfast or lunch. So what I usually do, I will give, let's say, for example, that 10 kilo child, 20 kilo child, 10 unit of basal. So I give 5 unit glargine dulu, because we know that the patient, they don't have any basal. So I give 5 unit dulu. I know that 5 unit will last until malam. So malam tu I give another glargine, which is 10 unit. But then I follow lah 10 unit every night. Faham kan? Jadi 10 unit every night. So for the remaining that, you know, for example, jadi 20 kilo child, for the remaining 10 unit of bolus tu, I can split into 3 unit TDS, something like that. So biasanya memang tak ada, there is no hard and fast rule. I just pick one number and then we gauge, okay. That's why I always monitor 7 points. Pre-breakfast, 2 hour post-breakfast, pre-lunch, 2 hour post-lunch, pre-dinner, 2 hour post-dinner. 2 hour post-dinner is actually pre-bed and 3 AM. Then I see lah, okay, whatever yang bolus yang I bagi tu, actually macam mana, cukup ke tak for that meal. Kalau persistently blood glucose tinggi, then we know that the basal tak cukup, the bolus pun tak cukup. And then for the first transition, I will overlap the infusion for 1 hour. So biasanya I kata, okay, stop drip semua, biar patient makan. After 1 hour post makan, then we stop the insulin infusion. That's how I transition patient lah. Okay, any other question? The rest faham tak?
Dr. Rashdan?
Yes.
When can we allow patient feeding?
When we allow patient feeding. Kalau dah DKA dia dah resolve, kau allow. You allow sajalah, don't worry. Sebab tu kita
once resolve lah.
Betul. Selagi
tak resolve,
DKA resolve tak boleh. Sebab tu yang problemnya Alwi, macam yang kita dengan Dr. Said tadi bincang, kalau benda yang resolve ni jadi malam-malam, so you tak nak transition dia tengah malam. Jadi kita akan buat besok paginya. So while waiting for that morning ni, berapa banyak insulin you nak guna? Yang tu you boleh buat sliding scale, I kata. Okay, you boleh buat sliding scale lah. So pagi tu terus transition. So I think once DKA resolve, patient is stable lah. Kalau patient ventilated tu memang maybe you tak boleh allow lagi kan, ataupun patient on inotropes you tak boleh lagi. Once the patient stable, tak ada contraindication for feeding, as long as DKA resolve, you dah boleh transition to basal bolus. Lagi cepat lagi bagus. Cuma I biasa pilih masa nak transition tu ialah masa makan. So kalau I rasa DKA dia resolve masa morning, I dah miss the breakfast, I will do it during the lunch, something like that. Okay. Any other question? Orang lain jangan malu dengan Dr. Rashdan, biasa je. You can ask question. Tak kisah. Tak semestinya Alwi, walaupun Alwi kena I, it's okay. Sesiapa pun boleh tanya. Alright. So I think I just go a little bit more on this case discussion. Oh, you all ada case scenario yang nak discuss dengan I tak? Maksudnya your personal experience from UIA, because you have a few cases yang you rasa apa yang you can, anything that you want to do differently ke, you want to get my opinion? Ada tak?
Dr. Rashdan, we've got one patient. Yeah, we've
Okay.
got one patient. Okay. Actually, but this not DKA lah.
Okay.
Patient not DKA, tapi patient ni is a newly diagnosed type 1 DM.
Okay.
An 8-year-old girl.
Okay.
Newly diagnosed in May.
Okay.
Okay. Why? Because I mean, when we read the CPG kan, usually at 8-year-old we start the TDD and the total daily insulin dose is usually around 0.7 to 0.8 unit per kilo per day kan usually.
Betul.
Tapi this child kan, dia started from beginning pun memang start at 1.4, 1.5 unit per kilo per day.
Okay. Pandai, faham.
So we are struggling lah because now we admit the child for optimization, for insulin optimization.
Okay.
And then we are using the carbo counting approach. So there's no fixed dosing except for the basal. Basal we got fixed dosing.
Okay.
Tapi for the bolus is based on carbo counting.
Betul.
Cuma it turns out the patient requirement is like 12 up to sometimes 15 unit acrapate.
Okay.
So the mother become like jittery lah and become worried because the insulin requirement is increasing despite patient should be in still in the partial remission period, tapi macam the total daily is about 1.5. So what are the factors that affect?
Okay. So I think so I will break your question into few points. Number one, total daily dose of insulin. So you are correct in the sense that pre-pubertal is around 0.7 unit per kilo per day. Pre-pubertal. So the majority of time is around 0.7 to 1 unit per kilo per day. But in those pubertal children, the insulin requirement can be up to 1.2 to 1.5 unit per kilo per day. So this is an 8-year-old child. So we are not sure whether the patient is into or entering puberty. So what you can do is you check the tenor staging lah. So if you feel that the patient is entering puberty, dah ada breast development, you check LH, FSH memang dah elevated, estrogen dah elevated, then you know that this maybe because of the pubertal dosing, which is around 1.2 to 1.5 kilo unit per kilo per day. That's number one. So number two is actually the technical. In terms of administration, so kita kena check betul-betul the technique of administration, whether they are injecting into the lipodystrophic site, yang tu memang you punya absorption will be very erratic. You want to make sure that the insulin is not expired. And then you want to make sure that they betul-betul lah administration ni kena tunggu sampai, kena kira sampai 10, the site is not lipodystrophy, the insulin is not expired. So in terms of technical issue, that one you have to tackle juga. So number three, this is a very rare condition, tapi boleh berlaku. What happened is they have insulin autoantibodies. As you all know, insulin is an autoimmune condition. So biasanya antibodies ni was directed to the beta cell pancreas. So maksudnya dia rosakkan, destroy the pancreatic beta cell. But some of the patient, they can have this insulin autoantibodies. So what happen is the autoantibodies dia tak attack pun pancreas tu, dia pergi attack whatever insulin you bagi. So whatever yang you bagi tu tak cukup lah, dia macam ada insulin resistant because of these antibodies. Okay. And number four, what happened in Malaysia is, although this is a type 1, our obesity is very, apa orang kata, high prevalence. So sometimes they have some evidence or some elements of insulin resistance because of the population obesity. You faham tak? Patutnya budak-budak type 1 ni, antibody dia positif, then dia kurus. Tapi because of our population is obese, so they inherit that some obesity. Jadi kalau you tengok clinically dia pun ada obese, ada acanthosis nigricans, then you kata, oh, there's some elements of insulin resistance as well lah. Cuma for me, this you have to tackle these four factors lah. Number one, the dosing itself, pre-pubertal, peri-pubertal, and pubertal is different. Number two, the technical aspect. Number three, the unfortunate event of having auto antibodies toward the insulin. And number four, the prevalence of obesity. Jadi you tengok yang empat perkara ni lah. And then number 5, patient tak compliant lah. Dia curi-curi makan depan kau, itu je.
Itulah. Okay.
Okay, alright. Any other question? Sorry?
Patient Ali tu patient daripada Kelantan tu.
Hantar balik sini.
Jadi patient Dr. Suhaimi.
Oh, patient tu macam anda hantar balik Suhaimi lah. Senang kan, hantar balik ke Abang Suhaimi je biar dia manage. Senang. Tapi I mean to share. Recently I got a baby, I got a child 2 years old. I punya insulin up to 2 unit per kilo per day tau. So I have to give lah. Tapi subsequently bila dia dah balik, dia start main-main, so the insulin requirement we can see came down. Sometimes because dia duduk hospital, dia orang tak aktif kan. Jadi insulin tu macam you tak gerak-gerak, jadi dia punya absorption pun tak bagus, and then dia orang tak aktif, dia orang makan saja. So it can be misleading juga.
Oh, okay. Make sense.
Okay, 3:30, you all to continue. I think the case study is very simple. Ke ataupun you all ada question? I rasa better I take question from all of you lah, because sometimes you all need to ask certain question kan.
Any questions from anyone? Students here, we have some students here. MO, faham lah korang? 10 minutes.
Sorry?
Masuk MO, where are MO? Come, ask questions.
So I mean, this one is UIA Master Student, UIA MO, HTAA MO. I pun tak pasti sebenarnya, Syed.
UIA MOs and some medical students.
Okay, some medical student and master student as well. Alright.
And UIA MO, no student.
Seorang je masih student.
Oh, ada masih student. Okay.
Okay. Alright.
Actually dari satu kan, dari Dr. Rashdan.
Yes.
I remember Dr. Suhaimi pernah mention insulatat ni, the problem with insulatat dia punya is predictable. Insulatat is unpredictable, dia punya absorption, so dia punya action is quite unpredictable. So kalau macam this kind of case kan, kalau kita tukar ke ada yang analog ke better ke ataupun macam mana?
Okay. So definitely Alwi, definitely glargine and levodopa is much better lah than insulatat. If possible, all my patient I would put on glargine as well as determine. Tapi unfortunately, you have to understand that Malaysia is considered a limited resource country lah. So sometimes you don't have glargine or levodopa at your center. So you have to make use whatever yang ada, because you cannot. You have to still manage the patient. So for example, patient ni kat Bentong you die you minta dia pakai levodopa, tak boleh lah kan. Jadi whatever yang you have to use, you can use it first. So even some of my patient, I use insulatat, but I think more importantly is you have to understand the mode of action, the duration. So for example, insulatat, if I need to use insulatat, sometimes I do it as a BD dosing tau, because we know that it's very erratic, dia tak sampai 24 jam. So I have to give BD dosing. So sometimes I do that. So because that's the only thing yang ada that particular hospital, I have to make use of it, and then terpaksa lah. In the ideal setting, memang semua orang kita put on glargine and determine lah. In ideal setting.
Okay.
Okay, cool. Okay, so I think we will stop here, Syed. How you feel about it?
Okay, I think it's okay, sir. Case studies and for the discussion, I hope we can do in the next session, inshallah.
Okay, cool. Boleh?
Okay. I think on behalf of Paediatric Department of IIUM, and on behalf of IIUM, I would thank Dr. Rashdan for spending some time with us, teaching us about DKA, a case that we have seen here many times, several times. Dr. Rashdan, I just want to say, my first experience with DKA was in 2009. During the H1N1 outbreak, we have a patient coming in with DKA and then H1N1 positive. 1 year, 3 months old boy. Was very complicated case, but very interesting for me actually.
Yes. Okay, I just to highlight one thing. If your patient is less than 6 months old, and I repeat, if your patient is less than 6 months old and patient has DKA, so most of the time it's not type 1 diabetes, it's a neonatal diabetes. So neonatal diabetes is very interesting topic. I dengan Syed memang suka part neonate ni. Neonatal diabetes ni dia punya abnormalities, genetic mutation is at the GLUT transporter, curve 6.2 SUR1 gene. So satu jadi hyperinsulinemia, satu jadi neonatal diabetes. That's memang my favorite topic. Dia nanti you akan belajar lah, loss of function, gain of function. Tapi tempat yang sama, mutation berbeza, dapat dua condition yang berbeza. Tapi because we can confirm genetic by sending the blood to Exeter UK, and then if confirmed genetically because of this neonatal diabetes, rather than insulin, we can give glibenclamide. Okay, but that's the mode because kalau hypo you bagi diazoxide, kalau hyperglycemia neonatal diabetes you bagi glibenclamide. Only in a confirmed genetic case lah, diabetes before the onset before 6 months old. So those yang 1 tahun 2 tahun can still be type 1. Okay. I think we can have a next session. Yang tu baru kita cakap pasal ICR, ISF. I know a lot of confusion there. So hopefully I can make a good session. Bila tu nanti I bincang dengan Syed, dengan Alwi. Tapi bagilah you all via dulu. Okay? And then later on I will share my step with Syed. Okay? For this session. Alright, cool?
Okay, Dr. Rashdan, thank you so much. And thank you to all the participants.
Okay, thank you for inviting me as well. Assalamualaikum.
And our session will have better for
Thank you, Dr. Rashdan.
Okay, bye.